Let's start with the next chapter, and that is immunology, something which is important both in path, micro. It is also very important when you go ahead and study medicine. So first I'll start with since it's a rapid review, I want to touch upon all the important topics, one-liners and the cramming up things that are going to come to you. First thing that we start off with the natural killer cells. You know, markers are a question that will definitely come, but I want to quickly tell all of you. Natural killer cells are the ones which have two arms, right? One is the stop arm, one is the start arm. So one is the inhibitory arm and one is the activating arm. Tell me one thing. If a self cell, if your own cell of the body comes, do you want to kill it? Of course not. So what is the ID card? How will, if you are my student, you will come to me with an ID card that, ma'am, I have got the subscription. This is my receipt. So you come with an ID card. Same way, the cell has to come with an ID card, and that ID card is MHC1. All our cells have been given an ID card called MHC1, and natural killer cell has been told that if you see the MHC1, wo ID card hai, I for 1 for ID card, you will pick up your inhibitory arm, you will not kill it. That is apna cell, self cell. So remember, if you see the presence of, as I say, if you see the presence of MHC1, which is ID card, you give the inhibitory arm. Whereas, if there is a cell which has got virus, or which has got cancer, do you want to kill it? Of course, yes. Viruses and cancers basically destroy the ID card. Viruses and cancers, they destroy the ID card. Now, are you going to kill them? Of course, I'm going to kill them. So, this activating arm is going to be NKG2D. It is NKG2D. This is the arm that is going to kill it. So remember, there is an inhibitory arm which will not let me kill my own cells, and there is an activating arm which will kill all the viruses and the cancers. I hope you've understood the concept of the self and the foreign antigens. What are the interleukins? Remember, for activating NK cells, you require 2, 12 and 15. For activating NK cells, you require 2, 12 and 15. Whereas what about the CD markers? CD markers are 16-inch bicep, 56-inch chest and 94 kg weight. Okay. So someone who's got the very bulky body, which you know 16-inch bicep is the ideal bulky body. 56-inch chest is of course going to be 94 kilos in muscle mass. So 16, 56 and 94 is this strong Bahubali natural killer cell. Okay, now natural killer cells are done. So we move on to the next one. This was what? Natural killer lymphocytes. But what are the other lymphocytes? T and B lymphocytes. So here I've got a T cell for you. Whenever a T cell has to pick up an antigen, what does it have? It has a receptor known as T cell receptor. T cell receptor is 95% cases it is made up of alpha beta, and only in 5% of the cases it is made up of gamma delta. Gamma delta wale T cells are pata hai kahan par? They are in GIT, GUT. GIT matlab GIT is gastrointestinal tract and GUT is genitourinary tract. So simple. 95% of the T cells have alpha beta receptors, T cell receptors. 5% of them have gamma delta T cell receptors which are present in GIT, GUT. Coming to the next, what are the CD markers? I have learnt it as 1 to 8, 28. We have learnt it as 1 to 8, 28. Easy to learn, 1 to 8, 28. But out of these, so here the CD markers will be present. So if they ask you that which is the pan T cell marker and the marker that carries the signal, so remember CD3. CD3 is the one that is going to be the present in all the T cells, pan T cell marker, and it will carry the signal from outside. So pan T cell and signal transducing is CD3. What is helper T cell? Helper T cell is going to be CD4. And what is cytotoxic T cell? That is going to be CD8. So they will ask you, what is going to be the ratio? CD4. Rather than writing it like this, I always prefer that we should be writing it like this. We should be writing it as in a numerical denominator numerator wala scene. Matlab CD4 upon CD8 is going to be 2:1, which means that rule of 8 has to be followed. Never make it 1:2. Always 2:1. Kyun? Because end mein 8 aana chahiye. 4 2s are 8 and 8 1s are 8. So that is how you should be going ahead. In the end, you have to get a total of 8. That is the rule. So please remember, if they say the CD4 upon CD8 count is reducing, this means what is the disease? CD4 count reduces in which disease? It reduces in HIV. And if they ask you the CD4 upon CD8 ratio is increasing in what? And that is going to be a case of sarcoidosis. So please remember, that is the CD4 to CD8 ratio. 2:1 normal hai. Increases in sarcoidosis, decreases in HIV. So the T cells are done. Similarly, we are going to do the B cells. What are the B cell receptors that you have? B cell receptors are actually to antibodies. Remember, in the full course videos I have taught you, B cells are blessed. Why are B cells blessed? Because they are blessed with MD degree. What you and I are struggling for all throughout our lives, B cells has been given the MD degree from childhood. How lucky. So B cells are going to have M and D. MD degree is already there. Now what are the CD markers? CD markers are 10s, 20s, 40s, 80s. मतलब double karte jao. So one is going to be 10. I hope you all remember that CD10 is also known as Kala. CD10 is also known as Kala. So 10s के बाद 20s आता है ना, so you will have 19, 20, 21, 22, 23. Lots in 20s that you've got. 19, 20, 21, 22, 23. Next you have 20s के बाद 40s पे जाओ. So they show you CD40. And finally 40 के बाद you'll go to 80, but not 80 exactly, 79A and 79B. So instead of making exact 80, you made it 79A and B, repeating. First in the 10s, then in the 20s, then in the 40s, then in the 80s. Which of these is the pan B cell marker? CD19 is the pan B cell marker. But which of these is the signal transduction molecule? That is CD79A and 79B. If you all remember, in the T cell, if you guys remember, that the pan T cell marker and the signal transduction marker were the same. That was CD3. Whereas in the B cells, please note, the pan B cell marker is what? It is CD19. And how will the signal go? If I make arrows for the signal, to kya lag raha hai? 79. So remember, pan B cell marker is 19, but the signal is going to go via CD79. Lastly, question from microbiology. How does Epstein-Barr virus enter the B cell? This is a favorite question of NEET and FMG. Epstein-Barr virus enters via CD21. I hope everyone's okay with B and T cell. Everyone's understood it, because now I'm going to tell you the next set of cells. So B lymphocyte, T lymphocyte, NK lymphocytes are done. Now let's move forward and see how do they talk to each other. So there I have a B cell. B cell is born with this MD degree, lucky fellow, and he is going to talk to his cousin brother T cell. So how? For example, if an antigen comes, B cell takes it and decides that I'm going to give my antigen to my cousin brother T cell. Why? Because T cells will then make interleukin 4. Firstly, you say, ma'am, itna easy nahi tha. When we read in our main course videos, it was very complicated, and I'll just add one line and that complication will go. For the B and the T cell to talk to each other, B cells have CD40 receptor and T cells have CD40 ligand. Basically, they will have to talk to each other, and then the T cells will release interleukin 4. You know why am I releasing interleukin 4? Whosoever gets what in life is never happy with it. All of you don't have MD degree, you want MD degree. B cell has MD degree, he wants something else. B cell says, MD to ho gaya, now super speciality karenge. Now I want all the other antibodies. I want GAMD, I want MD ke baad, I want GAMDE. I want all antibodies. How will I get all antibodies? So this interleukin 4 that I've got is going to come and going to change the MD into GAMD. So remember, this process is known as isotype switching. This process is known as isotype switching, and let me tell you, char chalis, how have I learnt it? If you want the antibodies to change, you will need char and you will need chalis. Means for the change, for the switching, you will need char, that is interleukin 4, and you will need chalis, which is CD40 ligand. So remember, for the change, you need char and chalis. Everyone's okay with this? This part of immunology is done. We are done with the B cells, T cells, NK cells. Now the next part that we are going to start off with is going to be the very, very famous MHC, Major Histocompatibility Complex, which you write as MHC. And how is MHC controlled? MHC1, MHC2, they are controlled by a gene known as or a chromosome, or a gene you can say, by a gene which is known as the HLA gene. HLA gene is present on which chromosome? It is present on chromosome number 6p, chota wala arm. It is present on chromosome number 6p. So what is HLA gene? I have drawn the structure. There is HLA gene part 1, HLA gene part 2 and HLA gene part 3. HLA gene part 1 is further divided into A, B, C. Then 2 is divided into DP, DQ, DR. So ABC se start karna. A, B, C, the next alphabet is D. So 2 is divided into DP, DQ, DR. 3 is not divided into anything. Remember, HLA1, when I'm talking about HLA1, that will make MHC1. HLA2 will make MHC2. What will this HLA3 do? HLA3 cannot make MHC3. MHC3 doesn't exist, na? So MHC3 doesn't exist. So what is it going to do? It is going to make complement proteins. It is going to make Complement proteins, for example, C2, C4, it is going to make heat shock protein, it is going to make TNF alpha, all these kind of things it makes. It doesn't make MHC3, ठीक है, MHC दो ही हैं, MHC is just going to be MHC1 and MHC2, that's about it. So a very famous question is that MHC3 तो नहीं होता, so what is HLA gene 3 doing? It is making all the miscellaneous complement proteins, heat shock proteins and so on. Out of these, we need to know the differences between MHC1 and MHC2, especially in micro and especially in your biochemistry. They are asked a lot. What are the differences between MHC1 and 2? Quickly, if we draw the diagram of these two structures over here. Firstly, in MHC1, you have to go in a clockwise manner. In MHC1, you'll go in a clockwise manner, means this is the alpha 1 chain, this is the alpha 2 chain, this is going to be the alpha 3 chain, and this is going to be beta 2 microglobulin. Alpha 1, alpha 2, alpha 3, beta 2 microglobulin. Where is the antigen going to come and sit? At the junction of what? Alpha 1, alpha 2. Antigen comes and sits at alpha 1, alpha 2. MHC2 का structure कैसे होगा? How do you write 2? Top, bottom, top, bottom. That is how you write 2 na, Roman numeral 2. So same way that when you'll have to do the labeling of this MHC out here, please note that there is going to be पहले ऊपर alpha 1, नीचे alpha 2. Beta 1, beta 2. Simple. Up, down, alpha 1, alpha 2, beta 1, beta 2. And MHC1 में कैसे था? Clockwise था. Now MHC1 में the antigen was sitting at alpha 1, alpha 2 junction. MHC2 में the antigen is sitting at alpha 1, beta 1 junction. अब exam में you'll say, ma'am, यहाँ तो I have understood. Exam में I'm not going to have that much of time of thinking the structure and where was the antigen sitting. कुछ quick method बता दो. That is what you guys always tell me, ma'am, some quick method. I want to solve questions in one second in the exam, and I hope you do. Okay, so easy ways. MHC1 has only one number na, तो only A. One number is what? First alphabet is what? A na. So only the alphas are going to be included in the antigen holding. Only alphas. MHC1 में only A alphabet. Alpha 1, alpha 2. MHC2 has 1 also and has 2 also. मतलब 1 alphabet is alpha, 2 alphabet is B, A and B. So alpha 1 and beta 1 will be included. हो गया simple? Where are they present? So your mnemonics are done. Where are they present? Please remember, MHC1 is present on all the nucleated cells of the body, and it is also present on the platelets, which means where is it not present? Red blood cells and sperms do not have MHC1. Red blood cells and sperms do not have MHC1. Rest all the nucleated cells and all the platelets have it. MHC2 is present on the antigen presenting cells. Whom do they present the antigen to? Antigen pakad to liya, they have held it, but whom will they give it to? MHC1 gives it to CD8 T cells, MHC2 gives it to CD4 T cells. Again, students get confused which is for CD8, which is for CD4. So again, rule of 8. Everywhere in immunology you get confused, do rule of 8. What is rule of 8? If they ask you MHC1 gives it to whom? Total 8 hona chahiye. So MHC1 will give it to CD8. MHC2 gives it to whom? So you will say MHC2 will give it to CD4 because 4 2s are 8, 8 1s are 8. So rule of 8 is always going to go in the immunology chapter. I hope everyone's okay with the MHCs. We fully understood it so that now we can move forward and talk about the different types of hypersensitivity reactions. Very, very important thing for all of us to know. How many types of hypersensitivities do we know? There are a total of 5 types of hypersensitivity reactions. Yes, earlier there were 4. Now there are 5 types of hypersensitivity reactions. But first, they ask you in the paper, what are their names? So acid mnemonic yaad karo. What is acid mnemonic? Type 1 is known as anaphylaxis. Type 2 is known as cytotoxic. Type 3 is known as immune complex mediated, and type 4 is known as delayed. Repeating, anaphylaxis, cytotoxic, immune complex mediated and delayed. And also having said that, please note that out of all these, there's another 5th one which I will tell you. Ye 2 mein se na, how we are going to make a 5th one out of it, I will soon come to that. But first, should we start off with the examples? Okay. Type 1 hypersensitivity. What was it? Acid का A, anaphylaxis वाला. So the mnemonic is ABCD. First class में क्या पढ़ते हैं? First class में we study ABCD ना, तो let's study ABCD से. A and B is all the different allergies and atopies and asthmas that you can think of. Every allergy coming to your mind. Allergic dermatitis, allergic rhinitis, allergic conjunctivitis, all the allergies. Even if that allergy is a bronchial asthma, even that comes. Even if that allergy is running in the family, father and daughter and granddaughter, everyone is having the same allergy. What is that known as? Atopy. So jitna bhi allergy situation, allergy in the family, allergy in the lungs, all these allergies come under it. Let me tell you, atopy has 5 alphabets. So which genetics determines that family is going to have allergy? Chromosome 5. So remember, ATOPY, chromosome 5 mein problem hai. Coming to C, always remember you've done a test called Cassoni test. Where have you done it? You've done it for echinococcus granulosis. So echinococcus granulosis matlab hydrated cyst, but now no one does it. I've told you na in the parasitology section of micro that you don't do it now. Coming to the next, that is what is D. D is going to be for drugs. So especially drugs like penicillin. So what is ABCD? Allergies, atopies, bronchial asthma, Cassoni test, drugs. Other than that, you have 2 more things known as the Theobald-Smith phenomena and PK reaction. They also come under type 1 hypersensitivity. Coming to the next one, we have the next thing, that is type 2. Type 2 mein kya tha? Acid mnemonic. Acid mnemonic is going to be, A was anaphylaxis, so C was what? C was cytotoxic. Now for type 2, you have my blood group is Rh positive. What is my blood group? My for myasthenia gravis. Okay, blood, all blood transfusion reactions, my blood group. So group for Graves and Goodpasture syndrome. Next, my blood group is all immune disorders, immune hemolytic anemia, immune thrombocytopenic purpura. So my blood group is RH. RH matlab RH incompatibility and RHD, rheumatic heart disease. My blood group is RH positive. P for pemphigus, P for pernicious anemia. Repeating, myasthenia gravis, blood transfusion reaction, a blood transfusion hai to RH incompatibility is also the same only na. Group mein kya aayega? Graves and Goodpasture. I for immune hemolytic anemia and immune thrombocytopenia, RHD and rheumatic heart disease and RH incompatibility, pemphigus skin disorder and pernicious anemia. All these are under type 2 hypersensitivity reactions. And please note, out of these, grave nikal lo. Take out the grave from here, take out the grave from here. Myasthenia gravis and Graves disease are now known as type 5. So that list we can make so easily. What is type 5 hypersensitivity now? As I said, both the grave things, myasthenia gravis and Graves disease, they are now said to be coming under type 5 hypersensitivity. Reason being, can you tell me? Graves disease is antibodies against what? Against TSH receptor. Thyroid problem hai na? Myasthenia gravis is what? It is antibodies against acetylcholine receptors. So basically the problem is that whenever there are antibodies against cellular receptors, that is known as type 5 hypersensitivity, particularly some cellular receptor like acetylcholine receptor, TSH receptor. So if 5 is given in the options for grave and grave, you will always mark 5. If 5 is not there in the options, then you will have no option but to mark hypersensitivity too. So type 2 hypersensitivity also done. Now let's move on to type 3 hypersensitivity. What is the mnemonic? It is sharp. S for, so the mnemonic is sharp. And S is for 3 things, that is SLE, serum sickness and Schick test. SLE, serum sickness as well as Schick test. Schick test, you all remember? Schick test is for what? Schick test was for Corynebacterium diphtheria, right? Okay. Next is going to be H. H is going to be what? Hinox-Schönlein purpura. I hope you remember Hinox-Schönlein purpura. We studied it. Go back to your vasculitis chapter in IgA. Even in the rapid review I have covered. It is an IgA vasculitis that happens in children. Okay, coming to A. A is going to be for arthris, is going to refer to localized immune complex. It happens at one part of the skin. It's not happening everywhere in the body. It's a localized reaction. What is R? R is something we don't really study nowadays, but Raji's assay. And there's one more thing known as reactive arthritis. What is P? P is the very famous, that is going to be PSG, and we all know post-streptococcal glomerulonephritis, you know na, cola color urine wala. So cola color urine wala is going to be type 3 hypersensitivity, and polyarthritis nodosa, that is also going to be type 3 hypersensitivity. So SLE, serum sickness, Schick test, HSP, arthris, Raji's, reactive, PSGN and PAN, all of these come under type 3 hypersensitivity. Finally, what comes under type 4? Everything that is to do with the granuloma. everything that is to do with a granuloma. So either it is TB or leprosy or any granuloma thing, and unka skin test also. So TB ka skin test is what? Monto's test. Leprosy ka skin test is what? Lepromin test. So all the granuloma disorders along with their skin tests, they come over here. Now tell me one thing. Another thing that you have to know, is there going to be any disease in the intestine? Of course, inflammatory bowel disease. We have studied which disease shows you granuloma. Crohn's disease shows you granuloma. Very, very important. That also comes. Anything with granuloma will come here. Na? The next one, what do you need to know about a brain disease? This most students miss out. Multiple sclerosis also shows you type 4 hypersensitivity. And finally, contact dermatitis. Contact to what? The same slide I've got you, which I taught you in your main course in Path and Micro, so that you study the same thing. Contact dermatitis, you'll say, ma'am, contact to what? So worldwide, it is contact to a plant known as poison ivy. It's a plant, so people come in contact with it and develop contact dermatitis. India में plant से नहीं होता है. India में और बहुत चीजें, like washing of clothes with hands, तो detergents की वजह से contact dermatitis happens. Women love wearing artificial jewelry, so in the neck, in the ears, or the tika, the sindoor, the bindi, these are the things which have a lot of artificial chemicals, nickel, cadmium, metals. So jewelry mein, bindis mein, all these things tend to have a lot of chemicals, and that is why women tend to suffer from contact dermatitis. So because abroad mein there is usage of washing machines, the hand usage of washing clothes is not that much. India mein bahut hai, so India mein contact dermatitis is an altogether different entity, different reasons. But worldwide, it's a plant called poison ivy. So guys, we finished off. Now if you want to quickly revise, the mnemonic was acid, and under this acid mnemonic I had told you anaphylaxis, cytotoxic, immune complex and delayed. Jaldi se mnemonic revision kar lo. Type 1 ka ABCD tha. The next one was my blood group is Rh positive. Then you had type 3 ke liye you had the mnemonic sharp. For type 4, you had all the granulomas in place for you. And type 5 mein what was there? Both the grave was there. Grave, myasthenia gravis and Graves' disease, they were all settled. Now there is a list of controversial entities. Rheumatoid arthritis and hypersensitivity pneumonitis, they are combinations of 3 and 4. They are combinations of 3 and 4. SLE is also going to be a combination of 2 and 3. How will I learn this? SLE, if you flip the S, you get a 2. And you flip the E, you get a 3. So now you know SLE is a combination of what? SLE is a combination of 2 and 3. Next, we are soon going to study something called transplant rejection. Remember, hyperacute is nothing but type 2 hypersensitivity. Chronic is nothing but type 4 hypersensitivity. And acute is actually a combination of both. It is type 2 as well as type 4 hypersensitivity. So repeating, hyperacute is just 2, chronic is going to be 4, and acute is going to be a combination of 2 and 4 hypersensitivity. These are the controversial ones that you have to know. Okay? Now we are moving forward. We are going to do a list of what? We are going to do a list of how the tolerance is broken and how your autoimmune disorders can come up. I know you studied autoimmune disorders in your medicine a lot. So what you need at this point of time is make a list of all the autoimmune disorders and let us know that what are the antibodies that are responsible for each one of them. I've made a list of these 3 autoimmune disorders: SLE, Sjogren's syndrome and scleroderma. Inka antibodies we have to know. So when I'm talking about SLE, I hope you remember the most sensitive one that you have over here is going to be anti-nuclear antibody. So anti-nuclear antibody is going to be the most sensitive antibody. What is the most specific? The most specific is going to be ASA. That is anti-Smith antibody. The most specific is anti-Smith antibody. So specific mein S aata hai, anti-Smith antibody, which is both sensitive and specific. Double benefit. So some double word will come. That is going to be anti-double stranded DNA. So I have learned anti-double stranded DNA antibody gives me double benefit, sensitive and specific. If a kid has SLE, anti-Ro antibody, because Rona is to do with neonates. Of course, Rona is to do with neonates. So neonates ke saath Rona. If there is SLE with psychosis, please remember psychosis mein P aata hai. It is anti-ribosomal P antibodies. It is anti-ribosomal P antibodies that is going to have the P for psychosis. Finally, if it is not SLE, but it is because of certain drugs, Can you please recall for me what are the drugs which are associated with drug-induced lupus? Something which is very, very important. क्या होता है? Drug-induced lupus is to do with those ship drugs, ना? I hope you remember. I'm not writing it because ये तो we've done 1 million times. ऐसे ही revise कर लेते हैं. What is ship drugs? S for sulfonamides, H for hydralazine, I for isoniazid, P for procainamide, D for dapsone. Sulfonamides, hydralazine, isoniazid, procainamide, dapsone. These are the ship drugs which cause drug-induced lupus, and they are associated with which antibodies? They are associated with anti-histone antibodies. So these were all the antibodies that were going to help you when it comes to SLE. The next disease that we have is Sjogren syndrome. Sjogren syndrome ka basic yaad hai? Sjogren syndrome was dry eyes and dry mouth. That was very, very important. So dry eyes and dry mouth wala syndrome is Sjogren syndrome. They ask you SNS, Sjogren syndrome. So which antibodies will be there? Anti-SSA and anti-SSB. Very simple. Do you think examiners ever going to ask you this? SS for Sjogren, SSA, SSB, nahi na? SSA is known as anti-Ro and SSB is known as anti-La, because Rona is always sensitive, na? So anti-Ro is always sensitive and La is always specific. So anti-SSA and anti-SSB are known as Ro and La. So Rona is sensitive, La is specific. Coming to the next, and that is known as a case of scleroderma. Now, scleroderma is of two types. Again, I'm going a little bit into, you can say, dermatology, but it's important. There is something known as limited scleroderma and then something known as diffuse scleroderma. Limited scleroderma is going to be anti-centromeric antibody. Limited scleroderma is anti-centromeric antibody. Diffuse scleroderma is anti-topoisomerase antibody. Anti-topoisomerase antibody known as anti-SCL70. How will I learn this information? Please note limited. Matlab limited part of the skin is affected. Scleroderma, na, derma matlab skin. So sclerosis of the skin. When limited part of the skin is affected, it is limited scleroderma. Diffuse means total body involvement is going to occur. That is how I learn my antibodies. Diffuse में क्या बोला? Total body involvement will occur. Total body involve होगा तो topoisomerase antibody होगा. Total body is affected, so topoisomerase. Why is it called SCL? SCL for scleroderma. SCL for scleroderma. So total body involved hoga to topoisomerase. And when limited, if it is limited to a place, to centered to a place, to centromeric antibody. How easy is that? Let's do a very quick 30-second review of this entire table. SLE के लिए sensitive is Anna, specific is anti-Smith. Double benefit, double-stranded DNA. Neonates के लिए Rona, anti-Ro antibody. SLE with psychosis, anti-ribosomal P antibody. Drug-induced with the ship drugs, anti-histone antibody. For Sjogren syndrome, let's go SNS. So SSA, SSB known as Ro and La. Rona is sensitive, so Ro is sensitive, La is specific. Scleroderma के लिए limited diffuse. Limited means centered, it is anti-centromeric antibody. Diffuse means total, that is anti-topoisomerase antibody. That wraps up your entire table of antibodies, which is very, very important. Now, after this, what they'll ask you is, all of these were ultimately type of anti-nuclear antibodies only. So they ask you that what is the methodology of measuring anti-nuclear antibodies, and that is known as immunofluorescence. So these are all the patterns that you have. Quickly revise with me. What are the patterns that we have? Very, very important patterns that you need to know for anti-nuclear antibody. Happens. What is the happens mnemonic? Happens matlab when the entire nucleus is affected. This is going to be the homogeneous pattern. Can you see that the entire nucleus has come out green? Next is going to be the peripheral or the rim pattern. The peripheral or the rim pattern is going to be just the periphery which is more dark. Next we have N. N is going to be nucleolar pattern. Nucleolar matlab only one dot. Nucleolus, one dot is coming out to be positive. Not everything else. Repeating, not everything else. One dot is coming out. Nucleolus is coming out to be positive. Sab jagah aisa dot coming, that is going to be speckled pattern. And let me tell you, speckled is the most common pattern in autoimmune disorders. Means it can be seen in SLE also, it can be seen in Sjogren also, it can be seen in scleroderma also. It is seen in all of them. Therefore, I will say it is non-specific. It is non-specific. And finally, what is happens ka C? C is going to be the centromere pattern or the centromeric. It is going to be the Centromeric pattern matlab centromere, it's reminding me of chromosomes. I can see chromosomes forming over here, so anti-centromeric pattern. So that is what we called as happens. Quick revision, you can see homogeneous, peripheral, nucleolar, speckled and centromeric, which is the most common, and non-specific out of these, speckled is the most common. I hope everyone's okay with this list of autoimmune disorders. Antibodies troubles you the most, this homogeneous happens, mnemonic troubles you the most. Both of these are sorted. What is it that we are going to move on to next? The next we start off with are 2 to 3 tables of immunodeficiency disorders. Again, something that troubles students a lot. So I've actually finished off immunodeficiency disorders in 2 tables. I don't know how I've done it. I also don't find it very believable, but I've tried my best. In 2 tables, I've written the, the different diseases, I've written the defects, and I've written the symptoms. And then I realized, ho sakta hai, we don't have to study it for 2 hours. We can finish it in 5 minutes also. So when you start doing it, you realize things are doable. When I talk about immunodeficiency disorders, be it path or micro or biochem or medicine, it's going to trouble you everywhere. So finish it off today. When we're talking about immunodeficiency disorders, table number 1, we have SCID, severe combined immunodeficiency. What is severe combined immunodeficiency? Firstly, how will we pick it up? Patient will come to you, the child will come to you with a red color rash on the face. Newborn child or a 6-month, 10-month, 1-year-old child, newborn rash on the face. That is going to be morbilliform rash. तो क्या होता है? Either it can be XLR or it can be AR. It can be XLR or it can be AR. So the way you write X, from that X, I want you to make a gamma out of it, because when it is XLR SCID, there is a problem in the gamma subunit of cytokine receptors. There is a of cytokine receptors, X ka gamma subunit. Okay. When it is AR, everything with A has to come. Either it is to do with A for ADA deficiency, okay, or it is to do with some gene which has A in it. So for example, there is something known as JAK3 gene defect. That is also AR type. There is something known as RAG1 and RAG2 gene defect. Those are also associated with AR. So repeating, AR is going to be associated with what? It is associated with ADA deficiency, JAK3 defect, RAG1 and RAG2 defect, and XLR is associated with gamma subunit. Ho gaya, easy. I hope it's very, very simple to pick up. There is no concern over here. Repeating, XLR में X का gamma subunit problem. AR में ADA defect, JAK3 defect, RAG1-2 defect. Overall, which is the most common? Overall, the most common is XLR, and AR में सबसे common पूछा तो ADA is the most common. See, so look at the question carefully. Out of the 2 inheritances, if they ask you overall, which is the most common, XLR is the most common. But in this AR variety, which is the most common, adenosine deaminase deficiency is the most common. Patient presents with morbilliform rash. Done. SCID is done. Coming to Bruton. Bruton ka to simple tha. B for Bruton, and you have B to pick up. Means Bruton's hypogammaglobulinemia is gonna occur in B for boys. It is a B cell problem and it is a Bruton gene defective. BTK gene defective. So kya hota hai? Patient has hypogammaglobulinemia. There is a decrease in IgG that happens. Go back to your second chapter. We have studied this. IgG is what? Opsonin, na? So if IgG is not there, this means patient is going to have defective opsonization. Defective opsonization shall occur. Simple. Coming to the next, what is Bare lymphocyte syndrome? Infection to hoga. Infection to dekho in sab mein hoga. Bare lymphocyte means lymphocyte was there but the covering was not there. What covering? MHC2 is missing. And this is a recent exam question that came, guys, in INI-CET. Remember, MHC2 goes missing. That is the Bare lymphocyte syndrome. Coming to the next one, DiGeorge syndrome. DiGeorge is catch-22. What is catch-22? It is deletion 22q that has occurred. When there is deletion 22q, I know that one gland that will not form is thymus. And thymus nahi banega, to T for T. The T cell will not develop. The second gland that does not form is parathyroid. Parathyroid nahi banega, this means the calcium levels are going to go down. Or in other simple words, I can say the patient is going to have hypocalcemia. The patient will have hypocalcemia. So simple, because there was a deletion of 22q, thymus nahi bana to T cell ka problem, parathyroid nahi bana to calcium ka problem. What else is going to occur? These patients are going to have cleft lip and cleft palate. They have cleft lip and cleft palate, and because of that cleft lip and cleft palate, they have abnormal faces. They have abnormal faces. Finally, what do they have? Cardiac. Cardiac matlab these patients suffer from tetralogy of Fallot. They suffer from TOF. So C for cardiac. That is what is catch 22. Cleft lip, cleft palate, abnormal faces, thymus and T cell problem, cardiac, tetralogy of Fallot, hypocalcemia, and catch 22. 22 is deleted. That is Digeorge syndrome. One slide is done. Coming to the next slide. Hyper IgM syndrome. Hyper IgM means that there is excess amount of IgM. Why? Do you remember I told you one story how MD degree was changing into GAMD degree, and that required char and chalice. So you will say that, ma'am, by chance, if the chalice is not there, this means MD will not change into GAMD. MD will continue being MMM. Why? Because there is a problem in 40 receptor or ligand. So hyper IgM is a problem in which there is a defect in CD40 receptor or ligand. Any kind of infection can occur, but Pneumocystis jirovecii pneumonia. Pneumocystis jirovecii pneumonia is very commonly given as a history in the exam that you should be knowing. Coming to hyper IgE, do you know what is hyper IgE? The name is only telling me that IgE will be more, and this is going to be job syndrome. So what have I learned? No one wants to work. Let's be honest. Let's admit it. Who wants to go for a job? I mean, we like to work, but sometimes we need days off, and sometimes we're like, oh, chuck the job. Why should I work? I wish I was, a princess and I did not have to work. I was a king or somewhere. I did not have to work. So every day, at least out of 6 days, you will have at least 2 to 3 days where you'll want to quit the job. So remember, you want to leave the job stat. You want to leave the job stat. So STAT3 gene defect is going to be seen in job syndrome, and that is going to be hyper IgE. So stat leaving the job, that is hyper IgE. Coming to isolated IgA deficiency means these patients are going to have IgA deficiency. This is not something that you need to know for FMG or NEET also, but for INI-CET, remember that in case any blood product is ever needed by these people, you have a person who's come to you with isolated IgA deficiency, and if that person is in requirement of any blood product, you should know that you have to give this person washed RBCs. That's a blood bank question that they're going to give you. You should give this person washed RBCs. Coming to the last one, Wiskott-Aldrich syndrome, WAS. So the genetic defect is simple. It is VASP gene defect. Wiskott-Aldrich syndrome ke liye VASP gene is going to be defective. Okay, now the way you say Wiskott-Aldrich syndrome, it is sounding like Wiskott-Aldrich syndrome was matlab past tense. Rule of life. Past tense ko bye-bye. When you have past tense, you are going to do bye-bye. What is bye-bye? These patients are going to have bleeding. Why bleeding? Because their platelet size is very, very small. They have small platelets. Next, you are going to say these patients will have infections. And third, these patients are going to have eczema. So please do bye-bye. What is bye-bye? There's going to be bleeding, there are infections, and there is eczema. So bye-bye is going to occur. So remember, the WAS is going to have a WAS gene defect and bye-bye will occur. Bleeding kyun hota hai? Because of small platelets. Very important set of information that you have. Finally, they ask you, what is the immunoglobulin profile? So, dekho, the way you write Wiskott-Aldrich syndrome, let us write it once more. The way you write Wiskott-Aldrich syndrome, whatever I will ulta karo, invert, that will go down. Whatever I will keep up, will go up. So, it's simple. What have I inverted? W ka ulta kara, M. So, what goes down? IgM goes down and A is kept as it is. So, A and E are going to go up and M is going to go down. Let me repeat all of this. Please note, in Wiskott-Aldrich syndrome, IgM is going to go down and IgA and E is going to go up. You've understood na? M kaise down jayega and A and E kaise up jayega. That is Wiskott-Aldrich syndrome. Bye-bye kar do. That is also become past now. These were all the immunodeficiency disorders. I told you we'll wrap it up all within 2 slides, and so we have. The next part that we are going to move forward to is going to be the transplant immunology. So 2 things left, transplant immunology as well as amyloidosis. Let's get going. When I talk about transplant immunology, you need to know first, what are you trying to transplant? What are the types of grafts that you have? Auto, iso, allo, xeno. Auto is simple. From my own body, I am putting something onto my own body. So auto means self-grafting. I for I, isograft means something which is, I've learnt it not just twins, I've learnt it as identical twins. So, isograft basically means that it is going to be between identical twins. Next, you have allo. Allograft means all of the people are of the same species. All of them are of the same species. For example, donor is also a human being. Recipient is also a human being. So if all of them are of the same species, then it's known as allograft. But if they are of different species, like for example, animal ka heart valve is being put into human beings, so different species are there, that is going to be a xenograft. So simple. Auto means self, iso means identical twins, allo means all of them are of the same species, and xeno means different species. So types of grafts are done. Grafting ho gaya. The problem doesn't happen there. The problem happens after a graft. The transplant is rejected. The graft is rejected. So for example, if someone has undergone a kidney transplant, after some time the kidney transplant will be rejected. So please note, in how much time is it getting rejected? If it is getting rejected very, very quickly, means if it is getting rejected within 48 hours, that is hyperacute rejection and it is a type 2 hypersensitivity. If it gets rejected after days and weeks, that is acute rejection, and that is a combination of 2 and 4 hypersensitivity. And if it occurs after many, many weeks, or in other words, you can say if it occurs after weeks or months, that is chronic rejection, which is just type 4 hypersensitivity. And let me tell you, chronic rejection is the most common rejection. That's a PYQ again that you have. Let's do a recap, guys. Hyperacute is type 2. Chronic is going to be type 4 and acute is beech mein dono ka combination, type 2 and type 4. So I've tried to make one table so that we can finish off all of this in one table. What did I tell you? Hyperacute is going to be rejected very, very quickly. Acute within days or weeks. Chronic within weeks to months, and chronic rejection is the most common. Now, why does this happen? See, when something will happen so quickly now, that basically means that there is something preformed. Basically means that this patient had preformed antibodies. That is why as soon as you put the kidney got rejected. So preformed antibodies किस में होगा? Either she is a multiparous woman who has lots of antibodies, or she has received multiple blood transfusions. He or she has received multiple blood transfusions. So more blood you receive, more antibodies also you're receiving from people. Na? So remember, if these people have too many antibodies that they've got, they will attack the kidney immediately. And if you attack the kidney, so just think common sense. This was a kidney that you placed in this person, kidney or a blood vessel. But kidney to ho gaya reject. The kidney has been rejected. So now the kidney is also being killed and the blood vessels are also being killed. Go back to your first chapter. What is the necrosis that happens in kidney? Solid organ ka necrosis kaun sa hota hai? Coagulative necrosis. And what is the necrosis that happens in blood vessels? That is known as fibrinoid necrosis. So you don't have to study anything new. If the kidney is being attacked, it is coagulative necrosis. And if the blood vessels are being attacked, it is a case of fibrinoid necrosis. Because patient had preformed antibodies, everything was happening very jaldi, that is hyperacute rejection. Next is going to be acute rejection. If you remember, this was a combination of hypersensitivity type 2, matlab antibody mediated, hypersensitivity type 4, matlab cell mediated. This means there is something known as acute humoral rejection, which is because of antibodies, and then there is something known as acute cellular rejection, which is because of cells. That is why acute humoral rejection makes it hypersensitivity type 2 and acute cellular rejection makes it hypersensitivity type 4. So please note, marker of acute humoral rejection is CD4D. Very important. CD4D going and depositing where? In the blood vessels. Let me show you one picture. This is the immunohistochemistry that you have for C4D. You can say complement hota hai C4D. So guys, what is the marker that you have for acute humoral rejection? It is going to be C4D. C4D, which is getting deposited in the blood vessels. So please note that this is C4D immunohistochemistry. I hope you've not forgotten. Immunohistochemistry means you're going to get a brown color. So here you are getting a lot of brown color around the blood vessels. That is what you're calling as rejection vasculitis. It is going to get deposited around the blood vessels. Next, if you're talking about cells, where are the cells getting deposited? Again, either in the blood vessels known as endothelitis or in the tubules known as tubulitis. So please remember, acute rejection, if it is because of antibodies, the marker is C4D. If it is because of cells, then you're going to see two things, that is tubulitis and endothelitis. Coming to the last one, chronic rejection. Chronic rejection is just type 4 hypersensitivity, means it is just to do with cells. And what is going to happen because of it? Goti happens. What is Goti? You'll say, ma'am, kidney mein kya hai? Kidney has glomerulus, it has tubules, it has blood vessels, it has interstitium. So all four things will get affected. When I talk about Goti, Remember, there is something known as, so we can take this up, divide the kidney into two parts: glomerular basement membrane duplication. Glomerular basement membrane duplication. What is O? There is going to be obliteration of the blood vessels. What is going to be T? There is going to be tubular atrophy that will occur. And what is I? There is interstitial fibrosis. This is for students whom I wanted who should recall it from the main lesson. I've got it separately also, guys. What is GOTI? Glomerular basement membrane duplication, obliteration of the blood vessel, tubular atrophy, interstitial fibrosis. So chronic rejection में GOTI होता है. Very, very important. So coming back, if it occurs very quickly, hyperacute, थोड़ा time बाद acute, बहुत time बाद chronic. That is most common. Hyperacute will show you fibrinoid and coagulative necrosis. Acute is combination. If it is humoral type, so C4D you have to learn. If it is cellular type, tubulitis and endothelitis. Chronic rejection shows you the very famous GOTI. And remembering their hypersensitivities again, hyperacute is 2, chronic is 4, and acute is beech mein, combination 2 and 4. But this is what? That the kidney got rejected. Transplant was rejected. Ulta ho gaya to? If the kidney comes and attacks the donor, in other words, I am talking about graft versus host disease. When I'm talking about graft versus host disease, means that the graft is going to come and attack the recipient. Graft is going to come and attack the recipient. Why would this happen? When the graft is very, very strong. The graft is very, very strong, that is immunocompetent, and the recipient bechara is very, very poor, and that is going to be immunocompromised. So means that you've put a kidney in someone, that person is like very, very dead types, very, very low in immunity, and you put a very strong immunocompetent kidney in it, the kidney will go and attack the patient. So remember, if this attack occurs within 100 days, it is acute GVHD, and if it occurs after 100 days, it is chronic GVHD. I want all of you to note one thing, that when I was talking about transplant rejection, hyperacute, acute, chronic, so do you remember over there I did not have any definitive timeline, days to weeks, weeks to months, etc. But when it comes to GVHD, I have a timeline. It is less than 100 days and more than 100 days. So fine, who is attacking? Imagine the kidney that I had put in the body, that has only come and started attacking. What part of the body will it attack? Skin, and the entire GIT hepatobiliary system is attacked. So in other words, first and foremost, remember, there is attack of skin, GIT and hepatobiliary. So in whether it is acute or it is chronic, these patients are going to have involvement of skin, intestine and liver. Let me give you some examples to begin with. So kya hota hai? Skin mein, for example, patients will have rash. Intestine mein, they are going to come up with diarrhea. Liver mein, of course, there's going to be jaundice. So these are the things that are going to happen. Remember, skin, intestine, liver. Many students, I've always told you to learn SIL, but students learn skin, intestine and then get confused liver or lungs. That is why I'm telling you, skin is one organ and the pura intestine and hepatobiliary system, the intestine and liver gets affected. That is graft versus host disease. So we are sorted with the transplant immunology also. What do we move on to next? The last topic that we have is known as amyloidosis. So let's get going. Amyloid, you know, amyloidosis is very simple. It's a protein, na? This everyone remembers. What is amyloid? Amyloid kya hota hai? Protein, lipid, glycogen, we all know it's a protein. 3 tables we have to do for amyloid and the story is going to be simple. So when I'm talking about amyloidosis, as all of you said, amyloidosis is nothing but an extracellular protein. And now I will tell you what are the different diseases that are coming under it. All these diseases can show you amyloid. So wherever I will use the alphabet A alphabet will mean amyloid. So batao, what is the amyloid that you see in multiple myeloma? It is AL. A for, I won't repeat, A har jagah amyloid. I will actually tell you what the L will mean. The second alphabet means light chain. Because multiple myeloma is a plasma cell tumor, na? Antibodies ban raha hai, to light chain. Fine. When I'm talking about these 3 situations, all chronic inflammations except chronic bronchitis. Other than chronic bronchitis, you name any chronic inflammation and we are sorted. Matlab, you say chronic pancreatitis, appendicitis, vasculitis or whatever. All chronic inflammations except chronic bronchitis. Cancers mein kya hai? Cancers mein any cancer. I'm just giving you some examples like renal cell carcinoma, Hodgkin's lymphoma. But otherwise, any cancers can show. and familial Mediterranean fever. All of them show you the presence of AA type of amyloid. So you would want to ask me what is AA? Pehla wala A to we know na, amyloid. Other is amyloid associated. It's an amyloid associated protein. So any inflammation, any cancer and any fever will show you AA. Medullary carcinoma. We all know medullary carcinoma shows you calcitonin. So the type of amyloid will be Cal. ACal. Cal stands for what? Cal stands for calcitonin. Next we talk about Alzheimer's. Alzheimer's मतलब brain disease है ना. Alzheimer's is going to be brain disease. So brain disease में क्या होता है? We have a beta type of amyloid. What does the beta stand for? Beta stands for beta plaques, because in Alzheimer's we have beta plaques na in the brain. Hemodialysis में the type of amyloid is A beta 2. You will ask me what is beta 2? Beta 2 stands for beta 2 microglobulin. Beta 2 stands for beta 2 microglobulin. So that is what you see in cases of hemodialysis. अब exam में confusion होता है. Where is A beta and where is A beta 2? So remember, one brain, so one beta, and two kidneys, so 2 beta. Simple. So when there is one brain तो एक ही है. Unfortunately, we have only one brain, and then students say, ma'am, exam में वो भी, that also stops working in the exam. One brain, so you keep one beta, and 2 kidneys are gonna be 2 beta. That is simple, na? Now the last one, the toughest one, which students say, I don't think it's tough. Systemic senile amyloidosis, old age wala amyloid. Familial amyloidotic polyneuropathy, nerve-related amyloid. You can simplify things. No need to learn such a big sentence. You can say एक है old age wala amyloid, one is the nerves wala amyloid. Both of them are going to show me ATTR. A for amyloid, and what is TTR? TTR stands for transthyretin. Both of them can show me transthyretin. So now you need to know, guys, that over here there is increase in quantity of transthyretin in senile old age wala, and in nerves wala there is mutant transthyretin. How to not get confused? As much as peak of the age, na, senile matlab very very old, a lot of age, a lot of quantity. Nerves is MNN, mutant. So remember, a lot of age is going to be associated with a lot of quantity. A lot of age, a lot of quantity of TTR. Whereas nerve related is going to be mutant TTR. So amyloidosis is sorted for us. Table number 1. Now in which organs was it getting affected? Please note the most common organ in which it goes is the kidney. But the most common in old people is going to be the heart. Okay. In kidney, the site. Kidney has mesangium, na? So kidney mein the site is going to be mesangium. Whenever something blood comes up, like heart or blood vessels, where does amyloid go? It is always going to be something subendo. So heart mein it is going to be subendocardial, whereas blood vessels mein it is going to be subendothelial. Heart mein subendocardial and blood vessels is going to be subendothelial. Okay? Now in the liver has a very famous space which everyone is aware of, and that is the space of Deci. In the spleen, either it can go in the red pulp or it can go in the white pulp. In the red pulp, I call it Lardaceous spleen. In the red pulp, when amyloid goes, I call it Lardaceous spleen. And when it goes into the white pulp, I call it the Sago spleen. How will I learn it? Dekho, Lardaceous is lal, red. And sago is sabudana, na? Sabudana is white grain. So remember, lardaceous is lal, that is red, and sago, sabudana, white. When it goes into the skin, it causes purpura. You call this pinch purpura. When it goes into the skin, it is going to cause pinch purpura. Where it goes into the joints, obviously, which joint am I talking about? Wrist joint. It is going to cause carpal tunnel syndrome. Wrist joint, median nerve, carpal tunnel syndrome. When it goes into the GIT, it causes organomegaly, means all the organs are going to become big fat, whether it is any GIT or any organ in which amyloid goes is going to become big and fat except one. Look at this. What is this? You can all see the shape only and tell me this is a kidney specimen. So all organs, number 1, are going to look waxy. Jab bhi amyloid goes into any organ, na, every organ, be it the heart or the spleen or the liver or GIT or any XYZ organ, sab kaisa candle wax ki tarah waxy, and all the organs are going to show you organomegaly. They are all going to become big and fat except except please remember the kidney, which is going to show you in the later stages. Later stages it might shrink. There may be decrease in size, but again I'm saying only in the later stages. Early stages mein kidney also becomes big and fat. Only in the later stages it is going to shrink. And how does it look? Every organ looks like this candle wax, and that is waxy appearance. So with that, guys, you have anyway wrapped up your entire discussion of the organs also. One last table left and immunology is over. The table is going to be how to detect amyloid. Let's get going. Gross stain. Abhi I told you na, jo waxy lag raha hai, you will be like, ma'am, can you confirm? Can I paint it with something and find out? Yes, I can paint it, and that paint is known as Lugol's iodine. So we have something known as Lugol's iodine, and that is going to give a mahogany brown color. There is Lugol's iodine and there's going to be a mahogany brown color that you'll get. What are the microscopic stains? See, these methyl violet, crystal violet, pass, ye to miscellaneous hai. You want to learn it, don't want to learn it, up to you. But Congo red and thioflavin T, very important. So what is it about Congo red that you have to learn? Congo red shows you the very famous apple green birefringence. Congo red shows you the very famous apple green birefringence on which microscopy? On polarizing microscopy. So first I'll show you the picture. Look at this, guys. पहले तो कुछ ऐसा pink दिख रहा था. I was like, I don't know what this pink thing is. So I decided that I am going to start using a polarizing microscopy and a Congo red stain. So suddenly on polarizing microscopy and Congo red stain, I started seeing this apple green birefringence. And when I start seeing apple green birefringence, immediately what comes to my mind is amyloid. What do you understand by birefringence? Birefringence, why is it shining? Nothing else. Nothing else in pathology. I have told you, na, aisa shine karta hua. Suddenly things are shining. Why is it shining? Then I got very, very curious about it. So then I did a technique called X-ray crystallography. On X-ray crystallography, I started seeing beta pleated sheets, and then I was like, okay, this is the reason that I see the birefringence. Please remember, they will ask you, what is the reason for birefringence? So the reason for birefringence is going to be the X-ray crystallography showing you beta pleated sheets. The stains are not over. Congo red was giving you apple green birefringence on polarizing microscopy. Now you need to know thioflavin T, TUV. Because they ask you that which is the amyloid stain that you are going to use on UV light. If you're using UV light, then which stain will you use? Thioflavin T. So remember TUV. Methyl violet, crystal violet, pass, these are all miscellaneous ones if you can learn. The last one, on electron microscopy, what is the diameter? It is 7.5 to 10 nanometers. On electron microscopy, 7.5 to 10 nanometers. So quick revision, gross stain, Lugol's iodine, mahogany brown color. Congo red, microscopically apple green birefringence on polarizing microscopy. Why does it have birefringence? Because X-ray crystallography shows you beta pleated sheets. Which light do you use for thioflavin T? For thioflavin T, we use ultraviolet light. Electron microscopy pe kya diameter hai? Remember that the diameter is 7.5 to 10 nanometers. But all of this is okay. From where did you take the sample? When you are suspecting a case of amyloidosis, please remember your sample can, earlier they used to say rectal biopsy lena, but now no. They say abdominal fat biopsy or abdominal pad of fat aspiration. That is a better sample to take than a rectal biopsy. So abdominal fat aspiration, very, very important. One last question which I want to tell the students who are appearing for INICT or higher institute exams. If you want to know the extent of amyloidosis, how much percentage of body is affected with amyloidosis, you are going to use a technique called scintigraphy. Again, FMG NEET ke liye nahi, but INI ke liye. So remember, extent of amyloidosis ke liye, you are going to check up on scintigraphy. That will help you know this. And on that note, we have wrapped up our entire discussion of the immunology chapter. I hope all of you have been able to gather it well, because the same comes in path, microbiochem, as well as in medicine. Hi everyone, let us begin with the next part of immunology, and that is a microbiology special, as I call it. That is the difference between an antigen antibody and how the antigen antibody reactions occur. So the first thing that you had to know were two definitions: antigen, what is immunogenicity, and what is antigenicity, and there's always a confusion between them, and I had made you learn it as AB, that antigenicity will refer to the binding, how an antigen binds to an antibody, that is antigenicity. But can it induce an immune response? I I for I, if it can induce an immune response, that is said to be an immunogenicity. I hope that is okay. So antigenicity defines as binding, and I for I, immunogenicity means induction. So that means if something can bind, binding matlab antigenicity to ho gaya. But does that mean that it will always result in an immune response? No. So whenever there is antigenicity, that doesn't mean immunogenicity has to be there. It may or may not be there. But the other way around, if immunogenicity has happened, if the immune response has already occurred, this means binding to hua hi hoga. Antigenicity must have happened. So these are the two statements that they ask you. They say that all antigens with antigenicity means binding, they may or may not show immunogenicity. Then it's a plus minus. However, if there is immunogenicity seen, that means antigenicity or binding, so definitely must have happened. Then we next need to know what is the definition of a pro-antigen or an incomplete antigen. Incomplete matlab bind to karega. It is gonna bind, antigenicity will be there, but it will not create an immune response. This is known as a hapten. It will bind, but it will not create an immune response. For example, if I say that I am talking, I am delivering the lectures, I am doing antigenicity, but you are not listening to me only, so I can't create a response in you. You are not showing immunogenicity, so I am working as a hapten, that I am delivering my lectures, but that's useless lecture because you're not listening. So that is a hapten. So what do? I can scold you, or I can give you some mnemonics, or I can, give you some notes. I can give you something that can get me your attention. So how can I convert a hapten into a proper wala antigen? I am gonna basically combine it with a protein carrier. So if I combine a hapten with a protein carrier, if I give you some extra mnemonic notes, funny stories, then you will say that yes ma'am, now we are listening to you, and now we are also able to recall everything. So now we have become a complete antigen. Yes, everyone's okay with this. Now let's go on to another definition. What is a heterophile antigen? Heterophile antigen means that if this is antigen A and this is antigen B, you will expect that antigen A and antigen B are different antigens. They are not at all same. But antigen says that one part of me and one part of antigen B are like twins. Antigens are sharing epitopes. So now, for example, if an antibody is formed, this antibody will be able to react with the epitope over here also, and the antibody will be able to react with the epitope also over here also. So antibody is going to show you cross reaction. So please remember, what is a heterophile antigen? Hetero matlab different, but they are loving each other. They are different, same but different, that kind of a thing. They're different, but they have little epitopes which are common. That is why antibodies are going to cross react. Two very famous tests that come under it: Paul Bunner test used in Epstein-Barr virus and Weil-Felix test used in rickettsia. Both of these are heterophile antigen antibody testings. Now let's go on to the next definition. What is a super antigen? Something that is going to do something super duper. So firstly, whenever they want to tell you super antigen, they will give you a history of a toxic shock syndrome, and one of the very famous examples causing toxic shock syndrome is Staphylococcus aureus. Why? Because they'll always give you a Gyneka example, that is a prolonged usage of tampons which has resulted in it. So what is a super antigen? I have got you the basics of immunology over here. I hope you all remember that whenever an antigen will come, it will come to an antigen presenting cell. Antigen presenting cell has something called MHC, and that antigen, I'm drawing an antigen in yellow, so this antigen has to be given via MHC to which cell? It has to be given to a T cell. T cell कैसे receive करेगा? It will receive it on a T cell receptor. So see how center to center the antigen is going. This is a normal antigen. From an antigen presenting cell via the MHC, it's going to go on to the T cell receptor. ये normal pathway है. But if I say my antigen wants to do something super, now there is an antigen which is not coming in the center, but is coming on the side. You can see it is coming on the beta chain of the T cell receptor. It is coming and attaching to the beta chain of the T cell receptor. Ma'am, side पे आ गया, मतलब that is super antigen, and you know what it's gonna do? ऐसा VVIP entry लिया है इसने, side से VVIP entry, not the routine line. It has come from the side, broken the line, and it has come and gotten attached over here. If it activates more than 20% lymphocytes, if more than 20% of these lymphocytes are activated, so many cytokines will be released that patient will start having TSS, toxic shock syndrome. So if you thought that only Staphylococcus can cause toxic shock syndrome, you are mistaken, because bacteria, not just super antigen is not just Staphylococcus. Bacteria, virus, even fungal organisms can act as super antigens. So please remember, Staph strepto, then dono Yersinia, that is enterocolitica and pseudotuberculosis, and even our famous Mycobacterium TB. These are the bacteria. When you ask me about the viruses, EBV, CMV and rabies, these are also my super antigens, and fungus mein Malassezia furfur. These are all super antigens. But what all can cause toxic shock syndrome? Staph and strepto can cause toxic shock syndrome, can be caused by Staphylococcus aureus and can be caused by Streptococcus as well. Done with the definitions. Now antigen pe to we have spoken a lot. Let me also talk about an antibody. This is what an antibody structure looks like. I hope you all remember antibodies were of 5 types, that is GAMD, from maximum to minimum, IgG, A, M, D, E. GAMD is how I learn it. So let me look at an antibody. I will say every antibody is going to have a big chain, and that is known as a heavy chain. How heavy is it? It is 50,000 Daltons. And uska thoda sa lighter version, chota version, that will become a light chain, and that light chain is just half, that is 25,000 Daltons. So how many heavy chains? 2 heavy chains. How many light chains? 2 light chains. How are they connected to each other? Can you see these SS? They must be disulfide bonds. Now if I zoom into each of these heavy chains and light chains, I will realize that every light chain has one variable, one constant region. One variable, one constant region. So light chain ka simple hai. One variable region, one constant region. Simple. The heavy chain has one variable region. Okay, it has one variable, but the constant regions are 1, 2, 3, 1, 2, 3. Either it can have 3 constant regions, or look at the next one, 1, 2, 3, 4. Ma'am, here it is having 4 constant regions. So when does it have? So variable to hamesha 1, 1 hi raha in the heavy chain, but constant regions have either become 3 or they are going to be 4. So remember that 4 constant regions, matlab it is very egoistic. Matlab it is having a lot of content in it. Matlab IgM and E are the ones which are me. So me, I am egoistic. ठीक है, तो me. So me, remember, IgM and E are the ones which have 4 constant regions, whereas all the others, that is, what is left? GAD, that is GAD, is going to have 3 constant regions. So now you will say antibody का तो हो गया मैम, थोड़ा और detail बताओ. At least one thing is certain, that both of them have one variable region. One for light chain, one for heavy chain. Where does antigen come and bind? Antigen comes and binds over here. This is where the antigen will bind. Matlab variable portion pe antigen is going to bind. So let me zoom in. If I look at this, these are the 2 variable regions. These are the variable regions. Antigen is going to come and bind over here. And do you know exactly what is the antigen binding site? It binds onto the variable ke andar bhi there is something known as a hypervariable region. And that hypervariable region is known as CDR, that is complementarity determining region. Complementarity determining region. That is exactly where the antigen is going to come and bind over here, right? I hope that is clear with everyone, because now I'm going to show you all the 5 types of antibodies. You're going to learn it in the form of GAMD. Why did I say GAMD? Because GAMD matlab it has gone from maximum to least concentration in the blood, which has been a recent exam question. So you will see that all of them are just like regular Y shape. कौन सा dimer में है? Which of them is going to be as a dimer? So remember that IgA can have a combination of 2 antibodies, and which of them is going to be a pentameric? Which of them is pentamer? Means 5 antibodies have come together, and that is going to be IgM. So let's get going. When I start with IgG, can it cross the placenta? Yes, it can cross the placenta. I've told you GAMD mnemonic mein this has the maximum concentration in the blood. Valency is obvious. If this is the antibody, it can bind 1 antigen here, 1 antigen here. So total valency is 2. We all know IgG is which inflammation? It's going to be pathology. Kaun sa inflammation? Chronic inflammation. Complement system. It activates which complement pathway? It activates the classical complement pathway. So remember, IgM and IgG activate the classical complement pathway. Finally, remember, if you go back to pathology, was IgG the best opsonin that you have? Yes. Out of which G1 and G3 is the best opsonin. So now I'm going to tell you, IgG has 4 forms: Ig, G1, G2, G3 and G4. With everything, I'm going to tell you one question. Please note, G1 and G3 are the ones which are the best opsonins. These are the ones which are going to cause opsonins. Ig, G4 is related with diseases. Ig, G4 diseases are the diseases in the body which lead to a lot of fibrosis, and they've started getting you a lot of questions now. IgG2 is the one that has least chances of crossing the placenta. So all of them can cross the placenta, G1, G2, G3, G4, but least chances of crossing the placenta are going to be with G2, that is IgG2. I'm going to come down to IgA. I'm going in that GAMD mnemonic. Okay, so G ho gaya. Now I come to IgA. And I had told you that IgA can either be existing as a single antibody. When it is a single antibody, you will know that it is roaming around in the blood. Single hai to serum mein hai. Remember, single, jitne alphabets single mein hai, 5-6 alphabets. Serum also has 5-6 alphabets. But when it becomes a dimer, that is going to be in mucosa and secretions. Dimeric form is seen in mucosa and secretions. Please note how is a dimer formed. So you can see one antibody here and one antibody here. Can you see there is a chain in the center which is known as the joining chain. Okay, joining chain hota hai, but that's not enough. You have to make a secretory protein. Double tape karo. Achhe se double tape karo. So you can see one double tape also here, and that is known as the secretory protein. So repeating, there is one thing to join it called the joining chain, and then there is one thing which is going to bind around it, and that is going to be the secretory protein, that is IgA. Very, very important. Now we come down to GAMD mein IgM, and M, as I can see, how many does it have? It is pentameric. There are 5 antibodies that it's going to have. So imagine how many antigens. Ma'am, one antibody can bind 2 antigens. So 5 antibodies can bind a total of 10 antigens. The valency is 10. If there are 10 seats in a metro, you will never want to sit right next to someone. You will say, ma'am, I left one seat because I wanted my space. Antigens also don't like sitting next to each other as a chipak ke. So the ideally valency is 10, but practically only 5 or 6 antigens are going to go and bind to it. I hope you've understood the concept. So I'm saying that, oh, quite a rich antibody. It can bind 10 antigens at the same time. So can I say it has maximum antigen binding sites? And at the same time, this is also going to be the maximum molecular weight. It is the Ambani of this family. It is quite a rich antibody. That is why I called it millionaire antibody. Distribution, please note 80% of IgM is said to be intravascular. It's within the blood circulation. This is the antibody which has started in intrauterine life 20th week. This has started by much before the 20th week intrauterine life. We all know that IgM is going to be a part of acute inflammation. It's going to start off early, and I have already told you that it is going to go and activate the classical pathway. Okay, one thing I wanted to tell you, if you remember from the starting of the chapter, B cell had a B cell receptor. Do you guys remember what was the B cell receptor? I told you B cell is blessed because it is born with MD degree. So if someone asks you what is the B cell receptor, you will say yes, the B cell receptor is IgM and IgD, and that is in front of you. Can, word INICET, can IgD activate the complement system? Ho sakta hai, yes. It can activate the alternate complement system. This is not something that we study very commonly, but it is something which can be asked in your INICET exam. So alternate usually IgA se activate hota hai, A for A, but also D can activate the alternate complement system. Coming to the last one, which is IgE, and IgE, as we know, it has got the least concentration. GAMD mnemonic it has come in the end, so it has got the least concentration in our blood. And what are the two names? These are two ratta names that you will have to do for IgE. It is known as the homocytotropic antibody and the reagenic antibody. But what is important from clinical point of view, it is going to be increasing in allergies and in parasites. So if you get a hookworm, roundworm koi infection aaya, ya fir any parasitic infection, or you get some allergy, dermatitis, allergic rhinitis or asthma or any kind of allergy, you will know that it is IgE that is getting elevated. These were your basics about an antigen and an antibody, because now I'm going to start off with how those antigen and antibodies are going to react with each other. We have two types of reactions that we study. One is a precipitation reaction, one is an agglutination reaction. Agglutination is said to be better, but difference kya hai, ma'am? Both of them are antigen antibody reactions, but P is not for P. One of them will have a soluble antigen, one of them will have a particulate antigen. तो precipitation में क्या रखें, soluble या particulate? You will say, ma'am, P के साथ P नहीं. You can't keep particulate antigen over here. You will keep soluble antigen here, and for agglutination, you will keep a particulate antigen. So let me start off with the first one. I'm starting with precipitation reactions, and I've got you one very simple flowchart in one slide so that you know one photo I tell you and I'm done. Precipitation reaction मतलब antigen and antibody will combine. Either that combination can occur in a liquid media or that combination can occur in a gel. I am talking about a liquid media first. Liquid में क्या है, ये वाला photo देख लो, everything is sorted. Liquid में you will say simple ma'am, here you have an antigen, here you have an antibody. Wherever the antigen and the antibody will meet, you will have a ring formation. तो जो ring वाला test है, Ascoli's ring precipitin test, A for A, Ascoli's ring precipitin test which is done for anthrax, ring precipitin is telling me that हाँ ring होगा and precipitation reaction होगा. Similarly for streptococcus, don't we do the Lancefield grouping? Quickly tell me for which streptococcus do we do? We do it for the beta hemolytic streptococcus and Lancefield grouping करते हैं. Which antigen do I use? I used to always mark the C out of it. The C antigen is used. So basically when you're doing precipitation reactions in a ring form, there are two things. Either you can do the Ascoli's ring precipitin test which you're doing for anthrax, or you can do the Lancefield grouping which is for streptococcus. The same thing, you say that ma'am, other than making a ring, you are gonna make floccules. So floccules के लिए there are two tests. Both these tests that I've written, one is a Kahan test, one is a VDRL test. Both of these are for what? Both of these are for Treponema pallidum, that is syphilis. So Kahan test, 4 alphabets, Kahan tube. So remember, Kahan test is a tube flocculation test, and VDRL, if you remember, I had told you in your syphilis chapter that VDRL एक slide पे होता है, there's a VDRL plate. So VDRL is going to be a slide flocculation test. It's very, very difficult because you have to see that slide under the microscope. We always used to study VDRL is very, very difficult test. Why very, very difficult? Because you have to look at it under a slide. So VDRL is a slide flocculation test and Kahan is a tube flocculation test. हो गया. So this is what all you did in a liquid media. Ring के साथ ring वाला reaction रखना and Lancefield, and flocculation के साथ tube flocculation, slide flocculation. Now the same thing you do in a gel. That is what I'm gonna come to. If you do it in a gel, please remember that this is where the story becomes a little difficult, but I will try my best to simplify it. So please note, if you're doing it in a gel, first you need to understand what is the definition of diffusion and what is dimension. Dimension matlab where are you doing the test? That is the concept. So that means if you're doing the test in a test tube or you're doing the test on a slide, dekho, test tube, how does it sound? It looks like a 1. So this is going to be 1 dimension. Slide कैसा होता है? Slide का S looks like a 2. So this is going to be 2 dimension. Simple. The slide test is going to be 1 and the slide is going to be 2. ठीक है? Dimension is clear where I've done the test. Diffusion means who is moving. If only and only antigen is moving, only one person is moving, this means it is single diffusion. If antigen and antibody both are moving, this means it's going to become a double diffusion. So simple, if one person is moving, if only I am teaching you, single diffusion. But if I ask you questions and you also start answering, dono baat karenge, that is going to be double diffusion. So simple, now you've learned the diffusion. Now what I'm going to show you, with the help of these 4 reactions, I will be able to explain to you all the names, and I know you guys find those names difficult. So let me see. पहले ये बताओ, I have 2 test tubes in front of me. Test tube मतलब कौन सा dimension? मैम T वाला लिखा है. If you have written test tube, so T means that you are talking about 1 wala dimension. Yes, you have written that. Very good. 1 dimension, 1 dimension. Now in these 1 dimensions, I have to see single diffusion, double diffusion. Single diffusion matlab only the antigen. Okay, so I'll try to summarize all of these in this one slide. The first thing that you see over here is I've made 2 test tubes. Now tell me, if I've used a test tube, what dimension am I dealing with? T looks like 1, so that is I'm dealing with 1 dimension. Dimension clear hua? So now you go into the diffusion. Single diffusion, double diffusion. Single diffusion means only one person is moving, that is the antigen is moving. Double diffusion means that the antigen is also going to move and then the antibody is also going to move. If both of them are moving, it is double diffusion. So remember, this is single diffusion and this is going to be double diffusion. So now what are the names of these tests? Ma'am, matlab to I have understood. The single diffusion in 1 dimension is known as the Audin test, and this double diffusion in 1 dimension is known as the Oakley-Fulthorpe test. Oakley-Fulthorpe test. How am I going to learn it? We had done a mnemonic called OOTD, outfit of the day. All of you are Gen Z people, love Instagram and hashtags, so here you go. Outfit of the day tells me whenever the test is done in a single tube, guys, tube matlab which dimension? 1D, so it is a single dimension. Now with one O, I will deal with single diffusion, and with the other O, I will deal with the double diffusion. ठीक है?
So these are the two tests that I have to know. Single diffusion में आउडिन, see आउडिन sounds like एक दिन. Audin sounds like ek din. So everything is ek ek. It is what? It is gonna be diffusion is also single, dimension is also single, Audin is simple, ek din. Whereas when I look at the other O double diffusion, ma'am, do O's include karo, ya basically do naam you will have to keep. It is going to have the Oakley-Fullthorpe test. You will have to have something that has two O's. So you will include Oakley-Fullthorpe test. This means for double diffusion, you have two O's that you have kept over here. याद हो गया simple. Audin पूछा तो सब 1 1 1 रखना. Single diffusion, single dimension. Oakley-Fullthorpe has two O's, so this means you are gonna go in with double diffusion. Now let's come on to the slide. As soon as I say slide over here and slide over here, you will say, अच्छा मैम ये भी slide है, ये भी slide है. If it is a slide, this means you are dealing with two dimension. Dimension is clear. Now I have a single diffusion and I have a double diffusion. Single diffusion is known as radial immunodiffusion. Radial immunodiffusion. How I have learnt it is very, very simple. If you look at radial immunodiffusion, you will see RID. तो RID में देखो, सबसे पहले radial. You will say, मैम radius में something is roaming around. Yeah, I can see radius. तो ये तो slide ही होगा. Slide मतलब this is going to be a two dimension. And ID is reminding me of single diffusion. ID is reminding me of single diffusion. So it is single diffusion in two dimensions. And what is this? This is my favorite. D. Double diffusion in two dimensions. What have I written? D. Double diffusion in two dimensions. This is known as the Outer-Loney test. How did we learn it? Because I gave you a mnemonic in the main videos. DD was the sister of Dexter in all cartoon series. So DD used to come into the lab and Dexter's equipments used to all break off and she used to really trouble Dexter. Dexter always used to do ouch. So remember, when DD comes into a lab, double diffusion, two dimensions, you are dealing with ouch. You are dealing with Outer-Loney test. And this is very important because this tends to show you so many antigens. This tells you, see what are DD and Dexter? DD and Dexter are relatives, brother sister na relation hai. This tells you the relatability of an antigen. Means what? If two antigens are same, dekho, if two antigens are same, if an antigen that is over here and an antigen over here, if these antigens are same, can you see the arc has crossed each other, the arc has fused. If an arc is formed, this means ye brother sister wale antigens hai, same. If the intersection happens, this means they are not at all relatives, they are not related. Dexter, DD are not related, the antigens are not related. And if they kind of cross, kind of fuse, that is known as a spur. So you will say, ma'am, partial identity, dur ka rishtedar. So simple. If the two antigens completely fuse, hug each other, matlab they are brother sisters, they are identical antigen. If they completely cross like this, matlab bilkul nahi, they are not at all related. Kind of meet, kind of cross, this means dur ka relative, kind of identical, partial identity. So now tell me, yahan pe kya ban raha hai? This kind of an arc that you are forming, are these looking as identical, unidentical, partial identical? Ma'am, proper fusion ho raha hai. This means this is going to be an identical antigen. All of these are identical antigens. And yes, that wraps up all of your precipitation reactions that are occurring in a gel. But now I want to make this process very fast. So I say that thoda electrical current laga do. And that is what is known as CIEP. Counter immunoelectrophoresis. I am just putting an electrical current from here and positive negative end bana diya. Why? Because the antigen will also start moving, the antibody will also start moving. When both of them will move, they will meet it, the thing will become faster. So please remember that this process is going to basically make it very, very fast because the antigen and the antibody are diffusing at the same time. Earlier again, this was used for a lot of things. Nowadays also we use it because electricity improves the movement. Finally, we have something called rocket electrophoresis. Rocket electrophoresis means that you can see the antigens are put in different concentrations. There are different concentrations of antigens and you're going to get different peaks. As the antigen will react with antibody, you're going to get different peaks or rockets. So that peak of the rocket will tell you the quantity of the antigen. Kam antigen hai, chota wala peak. Lots of antigen is there, lots of peaks. So that is known as the quantitative assessment. I hope everyone is okay with this because all your precipitation reactions have finished. Now what we move on to is going to be the agglutination reactions, which I told you in the beginning are better. They are better than precipitation reactions. They can be direct agglutination, antigen liya, antibody liya, direct. or they can be indirect agglutination. Please note, what is the difference between direct and indirect agglutination? This is direct and this is indirect. Direct मतलब पहले तो tell me, agglutination reaction, soluble antigen, particulate antigen. Ma'am, P was not for P, तो यहाँ P नहीं है. Agglutination is not with a P. So the antigen that I can use can be with the P. So if a particulate antigen is already there, antibody के साथ react करो and direct हो गया agglutination. But what if my antigen is soluble? I will first have to make it particulate. I will have to make it particulate. How? By basically absorbing it on something known as latex, or you can say RBCs. Basically you stick that antigen onto something and make it particulate, and then you will be able to carry out the reaction. So if you have a particulate antigen, it is a direct agglutination reaction. But if you have to convert a soluble antigen into particulate, then that becomes an indirect agglutination reaction. So we'll start one by one. Direct agglutination reactions can either be done on a slide or they can be done on a test tube. So I think slide wala agglutination to everyone knows. We all know blood grouping. Blood grouping is an agglutination test that we do on a slide, isn't it? Tube agglutination is everything else that you study. Tell me guys, what do you do a Vidal test for? Vidal is for typhoid. Standard agglutination, cold agglutination, all the agglutination tests. And you say, ma'am, if you want to do it under the microscope, then I will call it microscopic agglutination test. Okay, I'll discuss all these three: standard agglutination, cold agglutination and microscopic agglutination. Abhi karenge discuss. Wheel-Felix is an agglutination test. What do you use it for? We use it for rickettsia. Paul Bunnell, we use it for Epstein-Barr virus, and Coombs test is for knowing autoimmune disorders. So these are all tube agglutination tests. But I know you are worried about this CAT, SAT, MAT. So we all remember that mnemonic which we did in bacteriology also. CAT, SAT, MAT. Cold agglutination test, standard agglutination test, microscopic agglutination test. Remember a mnemonic. My cat sat on a mat. Who is my cat? My cat is my Billy. So my Billy is how you learn it. My stands for mycoplasma. So cold agglutination test is seen in mycoplasma. Billy ka B stands for Brucella. So standard agglutination test in Brucella. And microscopic agglutination test is going to be seen with Billy L, Leptospira. So remember, cat sat on a mat, and my Billy is how you learn all these agglutination tests, which are usually the tube agglutination tests. Moving forward, I know the last thing that you have been waiting for is the very, very famous ELISA. What is ELISA? Enzyme linked immunosorbent assay. This is an ELISA plate in front of you. I'm not going to go into the too much of depth of ELISA because that has been covered under the main videos, but basics I will be touching upon. What is an ELISA plate having? It has 12 wells in this direction, 8 wells in this direction. So total number of wells that it can have is 12 into 8, that is 96 wells. Okay, so what do I do for every ELISA? Direct, indirect, sandwich, competitive, koi bhi ELISA hoga. You will always use an enzyme for it, and that is known as horseradish peroxidase. The next thing that you will be, so dekho, you are saying ma'am enzyme use kara, horseradish peroxidase. Enzyme will always break something, na? So what is the substrate that you use? You use H2O2. And how will you get to know things have been, H2O2 has been broken or not? Give a color, and the color is benzidine. So these are the three things: enzyme, horseradish peroxidase, substrate that is H2O2, and chromogen that is benzidine is going to be utilized by all ELISAs. So let me tell you, out of all of these, if I come down to a very basic summary that you ask for, direct, indirect, sandwich and competitive, all of them are for antigen detection. So whether they ask you about direct ELISA, or they ask you about indirect ELISA, or sandwich, or your competitive, तो एक चीज याद रख लो, that in all of them I have antigen detection, but in indirect ELISA we are gonna do antibody detection. Okay? So now let me start off. Now the story is simple. When I start with the first one, that is direct ELISA, you will say, ma'am, everything is for antigen detection. So this means antigen jo pehle hai, that is the sample that you've got from the patient, blood sample, urine sample, whatever sample, that is what you've got. So now after that, ye to patient se aa gaya, right? Now what do you add? Antigen aa gaya, so you add one antibody. How will I know antigen-antibody reaction has occurred? I have combined that antibody with an enzyme, horseradish peroxidase. What will it break? I will add a substrate, that is H2O2. How will I know that it has been broken? I will add a chromogen. What was the chromogen? Benzidine. So that benzidine will be broken and I will get a color. So simple hai. If the antigen is present, I will get a color in the end. As easy as that. What is indirect ELISA? Indirect ELISA was for antibody detection. What am I wanting to find in my patient? I'm trying to find antibody. So that means that this is what I'm trying to find. My sample is the antibody. This is what I've got from the patient. Means the antigen is something that you will add. You will add the antigen in your lab, then you will add your patient sample, and then you will do the same process. You will add an antibody which has the enzyme. For the enzyme, you will have a substrate. For the substrate, you will have a signal. So simple. If the antibody was present in the patient sample, you will get a color in the end. What is a sandwich ELISA? Sandwich is also a type of antigen. बाकी सब तो antigen के लिए ही है. तो मैम sandwich बनाना है. This is an antigen that you've got. You have to make a sandwich between two antibodies. That is what a sandwich is. So this antibody you are going to add. This antibody you are going to add. This is going to be my patient's sample. Antigen I will add from the patient. तो ऊपर नीचे antibody and बाकी का process same. Antibody with enzyme and then substrate and then color. Finally, coming to the last one, and that is competitive ELISA. That is also for antigen. Competition. Who is a competitive student? A student who is basically very, very competitive will always study before the class. Even before the lecture has occurred in MBBS, he has studied everything in his hostel, not told anyone. बाहर से सब कुछ पढ़ के आया है. So there is an element of antigen-antibody reaction that you do before putting up ELISA. You take a separate test tube, you do antigen-antibody reaction. यहाँ उल्टा चलता है. That means if there is too much of antigen that is present, the end में the color is gonna be lesser. On the other hand, if the antigen was not there, the color is going to be more. So if you want to know too much of details of half an hour about it, please refer to the main videos. But the crux of the matter was that in competitive ELISA, competition chalta hai, antigen-antibody reaction has occurred beforehand only. So if the antigen is present, in the end you will not get a good color, and if the antigen is not present, you will get a good color. Basically, opposite scenario chalta hai. That is what is known as the different types of ELISA. The same principle is followed by last thing, that is immunofluorescence also. The only difference is that we have direct immunofluorescence and indirect immunofluorescence. इसमें भी either direct immunofluorescence you do for antigen detection, सब कुछ same चलेगा मैम. Indirect immunofluorescence you can do for antigen or antibody detection. Everything is the same. Patient का sample डालो, antigen antibody डालो, but the end result is not a color change. End result is a fluorescent dye. And what is the fluorescent dye that you use over here? That is FITC, fluoroisothiocyanate. Fluoroisothiocyanate is the fluorescent dye, and that is the question for immunofluorescence that you will get. The last part about the CART test, about an antigen-antibody reaction, is a rapid test called the CART test, which you know you can do for everything starting from malaria to syphilis to hepatitis to HIV to urine pregnancy tests to COVID. सबका CART test है. सबका CART test same principle. What is it? ICT. Immunochromatography. So immunochromatography is going to be the principle of all the CART tests. And question number 2, what is this white color membrane made up of? It is made up of a nitrocellulose membrane. It is made up of a nitrocellulose membrane. And on that note, you have wrapped up all of your antigen-antibody reactions. This was something which was micro special and I have not taught you under the pathology section.